Hello, everyone, and welcome to the April issue of DermSurgery Digest. I am Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. This month, we're excited to premiere our updated format, which will separate the surgical oncology and reconstruction portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Spotlight, will feature in-depth summaries and discussion on a few articles chosen by the feature editors. The second episode, Rapid Clinical Pearls, will cover the remainder of the journal, with the editors briefly covering clinical application of the data from each article. Our goal with this change is to make the content more digestible, with a focus on clinical application and enhancing patient care. Our feature editors for the April episode are Caresse Gamret with Genesis Dermatology, who will be providing the article summaries, and Sherrif Ibrahim, assistant professor in the Department of Dermatology at the University of Rochester, who will be providing the expert commentary. Thank you for listening. We hope you enjoy this new format, and as always, have a happy surgery day.
Welcome, everyone, to this month's DermSurgery Digest podcast. I'm Caresse Gamret, and our featured guest is Dr. Sherrif Ibrahim out of Rochester, New York. We will be discussing this month's surgical oncology and reconstruction articles from the April 2026 edition of Dermatologic Surgery. Without further ado, we will dive right into our first article, which is National Trends in Repair Type Selection After Mohs Micrographic Surgery, a benchmark analysis using TriNetX by Dowdell and colleagues. These authors used the TriNetX database to analyze over 600,000 Mohs cases performed between 2006 and 2024. Repairs were categorized by CPT codes and stratified by anatomic site, allowing for a look at national reconstructive patterns. They found that across all sites, complex linear repairs were the most common, making up about 34% of cases. This was followed by no same-day repair at 19%, which included second intention healing and delayed reconstruction, and local flaps, also at 19%. Intermediate repairs accounted for 18%, while skin grafts made up 8%. More advanced techniques like interpolation flaps and island pedicle flaps were rare, together comprising less than 1% of cases. Looking at trends over time, there were some important shifts. The use of complex repairs and island pedicle flaps decreased significantly. At the same time, intermediate repairs increased, likely reflecting reclassification rather than true changes in surgical behavior. Other repair types, like local flaps and grafts, remained relatively stable, but showed a slight downward trend. What's the takeaway here? This study gives us a national benchmark for reconstruction after Mohs, which is increasingly important in an era of value-based care and peer comparison. It also highlights how coding changes can significantly influence apparent practice patterns, something to keep in mind when interpreting trends or comparing yourself to national data. What did you have to say about this, Dr. Ibrahim?
I think you nailed it. The drop in complex repairs that was reported and the rise in intermediate closures that correlates perfectly with the CPT change, right? So it's not a change in how we're operating, not a change in how we're deciding to repair things. So it's not a shift in reconstructive philosophy. It's really just like an administrative artifact, like you said. So, but I think you made an important point. It's valuable for what you might call benchmarking, so that you can ask yourself as a Mohs surgeon, am I an outlier? How do I compare to national trends? What's going on around the country? I mean, it doesn't have variables like defect size, anything to do with patient factors, or anything related to the removal of the tumor and what the characteristics of the defect that were repaired. So it's not prescriptive in that sense, but it's definitely good for self-reflection, if you will, not for dictating how you would reconstruct something.
Definitely. And I also thought it was interesting that, sort of in looking back at your own practice, like, well, how do my percentages compare to this? Like, am I truly, doing second intention repair for that second intention for, a full 19%? I'm not sure, sort of to determine what's too much, too little, sort of that Goldilocks effect. How would you say that your practice compares if you had to ballpark it?
Yeah, I think we were right in line. Yeah, probably, I think it was 8% grafts or 9%. We probably don't do that many. We don't do that many skin grafts, but between linear closures and flaps, that's the bulk majority of what we do, and probably a good 15 to 20% granulation, particularly on the ear, and like a couple today I had right here actually at base. There were two today that we granulated, so they kind of come in waves, it seems like, but more or less when you average things out over the year, I think I'm pretty much right in line with what was reported here.
Awesome. Yeah, same. I think that definitely the lower extremity, I'm not eager to repair. So that probably, you know, bolsters my number of second intent. But
Absolutely.
yeah,
Great.
awesome. Okay, so we can move right along. Up next, we are discussing an article by Cooper et al. Entitled Incidental Histologic Findings During Mohs Micrographic Surgery, a Systematic Review. While Mohs surgery is designed for precise margin control of known tumors, we occasionally encounter incidental histologic findings, unexpected pathologies unrelated to the primary lesion. This study aims to better characterize how often this happens and what we're finding, and what it means clinically. The authors analyzed 29 studies encompassing 680 patients. While most primary tumors were basal and squamous cells, a wide spectrum of incidental findings emerged, ranging from benign entities like syringomas and syringomatous hyperplasia to more concerning diagnoses, including Merkel cell carcinoma, melanoma, and even hematologic malignancies. Notably, although many incidental findings were benign, a substantial portion had clinical implications. In aggregate, over 90% of reported findings required additional treatment, although this was heavily influenced by one of the larger studies, which focused on incidental keratinocyte carcinomas. Outside of that, only 16% of incidental findings still required further management. Most of these findings were in the high-risk zone H areas, and categories included adnexal tumors, malignancy, inflammatory, infectious processes, and even iatrogenic artifacts like dermal fillers. Key takeaway here is that most surgeons are uniquely positioned not just for margin control, but for identifying unexpected pathology. Maintaining vigilance and involving dermatopathology when needed can significantly impact patient management and outcomes. I thought that this was interesting in that it seems like such a difficult thing to report, because how often do you find some, benign hamartoma in your Mohs slide, but you don't often report it. So it was interesting that they're trying to classify this, but I definitely think this article is going to be subject to some like reporting bias. What's your take on it?
Absolutely. I mean, you have 610 cases out of 680 from one paper. Realistically, whenever you do a biopsy or look at a skin histology specimen anywhere on the face, you're going to find quote unquote incidental findings, right? Because it's just packed with things like syringomas and, is a hair follicle an incidental finding? I mean, it's sort of, where do you draw the line as what is an incidental finding? Where it comes into play in our day-to-day practice is when we see incidental tumors. So, we oftentimes will be doing Mohs for, say, a squamous cell cancer, and we see an incidental basal cell cancer, or vice versa. I've had incidental melanoma in situ that we've confirmed with MART1 stains for, Mohs surgery for a basal cell. We actually published a little series on that. So those kinds of things are incredibly impactful and really stress what you mentioned, is that we are uniquely positioned to be on guard all the time, right? So you shouldn't, if you're doing Mohs for a basal cell, you shouldn't only be looking for basal cell. You should be really scouring the slide, all the epidermal margins, the dermis, the fat, all around, because we can find these things in a very surprising fashion, not uncommonly. I don't think it's that it's impossible to say how often do we find a quote unquote incidental finding, but an incidental additional tumor or tumor characteristics, definitely we always have to be on the lookout for that. And, subtly changes the way we look at every slide, when you think about that.
Yes, absolutely. My most feared thing, not that it's ever happened to me clinically, is like finding, a desmoplastic melanoma or something like that. Definitely having that in the back of your mind
Mhm.
as a what's the worst case scenario here, um, comes to mind. And even things that they didn't really emphasize this, but even if you have like a CLL patient, how you have, more dense inflammation, can be something that comes to mind as well.
Yeah,
Even if you have
absolutely.
a clear margin, just that they tend to be more inflammatory.
Mhm. Yeah, I remember as a fellow, we diagnosed someone with CLL looking at their Mohs section because we saw that. I've seen the desmoplastic melanoma on what was previously biopsied as a melanoma in situ. Also, the main reason why we send that central debulking quite commonly, I think most people do that even when you're doing MART1 melanomas, looking at the margins with MART1, but sending the central debulk for permanent sections is so important for that reason. But
Absolutely.
definitely, you got to be on guard all the time.
And then another thing that you can think about, even if you're not certain what's going on, is like thawing the block and sending it off for permanence if there is something that catches your eye. Not that I find myself doing that commonly, but it gives me, peace of mind knowing that, hey, that's always, even if I'm like, I don't know what I'm looking at, quite frankly, but being able to send it for permanence is helpful. Is that something you do in your practice as well?
Yeah, absolutely. I mean, I just something that came to mind last week. The biopsy said squamous cell carcinoma in situ. We started getting into it, and it had single spindled cells everywhere. And we didn't know what it was, and it ended up being a very deeply invasive spindled cell squame with very bad perineural invasion. And again, the original biopsy said SCC in situ. So we thawed out some of the blocks, sent it in to better characterize it. So
Absolutely.
happens not uncommonly.
Yes, definitely remain vigilant, folks. Um, Next, we can talk about a way to assist in our patient's comfort with an article entitled Vibration Assisted Anesthesia Reduces Pain in Dermatologic Procedures, a split lesion study by Mohs and colleagues. Pain during dermatologic procedures, especially injections and PRP, is a major barrier for patients, and even local anesthesia can be anxiety provoking. This study evaluates a wearable vibrating kinetic anesthesia device based on gate control theory as a non pharmacologic way to reduce pain. In this prospective split lesion study of 629 patients, each patient served as their own control, undergoing the same procedure with and without vibration assistance. Pain was measured using the visual analog scale and numeric rating scales. The results were striking. Pain scores dropped by about 2.5 points on average, which meets criteria for a clinically meaningful reduction with a large effect size. Additionally, nearly 95% preferred the vibration device for future procedures. The pain perception also quantitatively improved, shifting from descriptors like stabbing and burning to dull and prickling. The effect was even more pronounced in painful procedures like PRP. So, what's the takeaway? Vibration assisted anesthesia appears to be simple, safe, and a highly effective adjunct for reducing procedural pain in dermatology without added medications or downtime. I thought this was kind of a cute article in the way they did this, like internal control for the patients. And this is something that I absolutely implement in my practice. Anytime that I'm caught like numbing for my own biopsy or doing my like numbing before a Mohs stage, I grab my little vibration device, which is not the same that they published, which was like an actual wearable device. But I find that my patients really appreciate that. It takes no extra time to numb, but I do think that it sort of distracts them enough that the pain that they are perceiving is lessened. And I think they also just appreciate the extra, step on my behalf to the point where many of them comment and are like, oh, I've never seen that before. No one's ever done that, even though I've had countless of these in the past. Is this something that you have in your office?
We have one of those little vibrating gold bar things. We don't. I mean, to be honest, we don't use it very much because it's efficacy and workflow, and sometimes it takes more time to get it than just to do a good quality injection. I thought that the gadget was pretty neat. I liked it because you could have multiple points. You could kind of straddle the injection site where most of the vibration bars just have, of course, the one point of contact.
Exactly.
I agree with you. I like having the internal control because the pain sensation is so variable. Like we know, right? Some patients, they're like crying in pain just when you walk in the room. Others, they're like, I feel it, but just keep going, doc. Like they don't, nothing bothers them. And then there's everything in between. So by having that internal control, I thought that was a great idea. You know, that first injection, right, we know is so important. I think most of us really pride ourselves in delivering as little painful injection as possible, but whether it's using a very high needle gauge or buffering our lidocaine, distraction techniques are so important. This can come in very handy when you have that really needle phobic patient, pediatric or anxious patients. Some cosmetic areas just hurt, cosmetically sensitive areas hurt a little bit more, like the rim of the ala, but it's just a nice touch to have available. So
Yeah, absolutely. You emphasize the way that they were straddling the injection site. And I think that that is something that I don't currently do, but would be good to have some sort of like two prong or this specific device to further kind of distract. You're right, though, workflow wise, if you're not in the habit of using it, you just are like moving along so fast, you don't think to grab it. So I try and keep mine, in my pocket and wipe it down like with alcohol right before doing the injection itself.
that's smart. Oh.
Yeah. Otherwise, you're moving along rather quickly. But so many of my patients are like, "Oh, are you sure we're not going to do topical numbing before this injection?"
Yeah.
No, we don't have time for that, but I will do the vibration.
Yeah, to be honest, I don't think topical works that well for injection.
No,
Maybe
it
there's
doesn't.
a
And I mean,
placebo effect.
I think there
But
are studies that look at that there's not good efficacy, but
yeah,
a
I
little
think
placebo effect.
absolutely. At the end of the day, I think good injection technique trumps everything, and I think most surgeons pride ourselves on that. So.
Absolutely. Um, Okay. Next, we can discuss Merkel cell carcinoma with an article by Joshi et al. Impact of prior malignancies on survival of patients with Merkel cell carcinoma. Patients with Merkel cell carcinoma are known to have higher risk of multiple primary cancers, but the impact of prior malignancies on outcomes has not been well defined. This SEER-based study explores whether a history of prior malignancy impacts outcomes in patients with Merkel cell carcinoma. They analyzed over 8,700 patients, and the authors found that having a prior cancer does not worsen Merkel cell specific survival overall. However, it does reduce overall survival. This suggests that there are competing mortality risks rather than more aggressive Merkel cell biology in most cases. However, an important caveat is existing here, and it relies on the nuance regarding hematologic malignancies. Patients with prior CLL or chronic lymphocytic leukemia did have significantly worse Merkel cell specific survival and overall survival, likely reflecting the underlying immunosuppression in these patients. Similarly, prior non-Hodgkin lymphoma patients were also found to have worse overall survival and a trend towards poor Merkel cell specific outcomes. In contrast, prior solid organ tumor patients, like those with breast, prostate, or colorectal cancer, did not have a change in their Merkel cell specific survival, although some, particularly those with lung and colorectal cancers, were found to have worse overall survival. The bottom line, a history of malignancy doesn't uniformly worsen Merkel cell outcomes, but prior hematologic cancers, especially CLL, are important prognostic red flags and should factor into risk stratification and multidisciplinary management. I thought this was an interesting case in that it sort of affirms what I think that, we've long thought, but it had a pretty good data or it's a sample size here to look at to confirm that CLL can be detrimental to these patients.
Yeah, I mean, again, I think like you said, it really something we've all kind of known, but it's nice to put some data to it and larger numbers. I think sort of the central idea here is that maybe these prior malignancies are a proxy for something else, whether it's immune dysfunction or carcinogenic exposure, both, where we already know that Merkel cell is really immune-related tumor in a way, how it responds to immunotherapy, the association with Merkel cell polyomavirus. And so anything that impairs immune surveillance, like all these hematologic malignancies, or age for that matter, are going to impact things. And also a lot of these patients are older, right? And so older patients have decreased tumor surveillance. Older people get more cancer. So, it's not, we can't really say it's causation, of course, and association and causation are very hard to separate. But at the end of the day, it's vigilance, right? And it's increased vigilance in these patients with hematologic malignancies. We're going to be watching them more closely for skin cancers, which most of us already do, right? Our CLL patients fall in that category, like transplant patients, where I watch these patients so closely and have lower thresholds for potentially more aggressive treatments because of the bad outcomes that we've seen. So nice paper just to quantify it and publish that.
Absolutely. And could also affect your frequency of if you're doing scans to follow up with Merkel cell, which is sometimes an area of my, how long and how often, there are some guidelines, but I find them to be a bit hazy. I think would definitely, weigh in my decision making for patients with these hematologic malignancies a little bit more heavily. And like you said, something that we've sort of suspected, talked about, but having hard data is always helpful in terms of ensuring we are evidence based in our recommendation.
Exactly. Well said.
Oh, why, thank you. Finally, we will talk about risk factors and microbial shifts in surgical site infections following Mohs surgery with second intent healing by Conde et al. Second intention healing is commonly used in Mohs surgery, particularly on the lower extremities, but concerns remain about infection risk and optimal antibiotic use. In this prospective single center study of over 6,600 Mohs cases, about 13% healed by second intention, with an overall surgical site infection rate of 1.4%. Still low, but notably the highest amongst any of the repair types. The key findings are particularly interesting from a microbiology standpoint. Among patients who developed infections, most had received gram-positive prophylactic antibiotics. Yet, the majority of infections were gram-negative, especially Pseudomonas. In contrast, patients who did not receive antibiotics had a more mixed microbial profile, including topical gram-positive organisms like Staph aureus and Staph epidermidis. In terms of risk factors, larger defects over 400 millimeters squared and lower extremity location were independently associated with significantly higher infection risk, up to 7-fold higher for leg and foot wounds. So what's the takeaway? While surgical site infection rates remain low, second intention healing wounds, especially on the lower extremity, carry a higher risk. And current gram-positive focused prophylaxis may actually shift the microbiome towards gram-negative infections. We may need to rethink antibiotic strategies in high-risk wounds and place greater emphasis on wound care and patient education accordingly. And this may mean that in future we rely less on routine prophylaxis or change those antimicrobial agents somewhat. What are your thoughts on this?
First, I want to commend the authors because it's so rare to see a prospective study when it comes to wound infections.
Absolutely.
To do that, I mean, kudos, because that right there makes it a sort of more impactful, credible study, because so many of the wound infections, almost all of them, are retrospective in nature. Key takeaways here is kind of reinforcing what we already know, that lower legs behave differently. They have a little bit higher infection risk, a little bit slower healing. So that's where vigilance is definitely going to matter most. So I think it reinforces that. There's this question of colonization versus infection, and whether or not, we're swabbing wounds and just picking up colonizers versus true infection. So again, at the end of the day, it doesn't necessarily change our practice, but it reinforces where we're already very cautious, which is these lower leg wounds. And I'm not about to start prophylacting everybody. We see them back, and if there's an issue, we put them on, meaning a culture positive symptomatic infection, then we would cover them.
Yeah, and I think that part of this increased risk on the leg certainly is, I mean, it's a location where gravity is not doing us any favors in terms of, like GI bacteria and their dependent wounds, but also they just take so long for second intention healing that I think that is really a strike against them. But I did definitely appreciate the fact that they had, over 6,000 patients in a prospective study. That does make this study unique, because there have been some things that challenge that, historic dogma that, if you don't sew a wound shut, you're not closing any bacteria into that closed space. It's less likely to have infections. But I think we've come to realize in years past that, legs are at risk even when they are just second intent healing, even though sometimes I try and convince my patients otherwise. But
yeah, also it takes a huge amount of compliance on the patient. They have to clean it. They have to, put some Vaseline on it. And a lot of them just don't. So yeah, it does take a long time.
Another thing that I like to do for my second intention wounds on the legs is sometimes do dilute vinegar soaks, which, is thought to have really good adequate gram-negative coverage. Is that something you use to try and prevent, gram-negative infections? And does that mean we're pushing them towards gram-positive infections, or what is that doing, perhaps?
We get these little mini, they're like 15 ml bottles of chlorhexidine, and we just give it to the patient and just say, put this in your shower, really suds it up, wash out your wound every day. And that's really cut down. It's essentially, minimal risk. There's some people that have contact allergy to chlorhexidine. That's pretty rare. But it's, for us, cut down our lower leg infection rate to almost zero when patients use that. They like that. They feel like they're getting something. It costs us like 30 cents, or just give it to the patient. And they don't need very much of it. And it seems to be working.
Awesome. No, that's a good tip, especially, or I mean, even if you're not doing it routinely for every patient, but implementing that for patients who have a history of surgical site infection or particularly large wounds that are going to be more delayed. That is a great pearl.
Mm-hmm. Lower legs, pretty much everybody gets it. So we just say, keep it in your shower, make sure it gets really sudsy when you use it, and then you can use a regular soap if you want after that.
Awesome. All right. Well, that concludes our spotlight session. Thank you so much for your expertise. Certainly, we had some thoughtful discussion. And with that, stay tuned for further publications of our podcast. Viewers, thank you so much.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.